Good evening, everybody. Uh, Thank you very much for your taking your time out for attending this meeting, which is on the renal cell carcinoma webinar. And in today's webinar, we are fortunate to have experts across the country, and we have joined with Professor Guillermo, who's gonna talk us about the RCC and how to treat RCC in today's time. We are going to cover the agenda. There is a lot of things to cover. Dr. Amit Joshi is trying to join. Meanwhile, I can go to the introduction of Dr. Amit Joshi. Next slide, please. Yeah, I guess within India, Sir needs no introduction. Sir is a professor of medical oncology at Tata Memorial Center here in Mumbai. And Sir is one of the leading medical oncologists who is specialized, or our focus area of Sir is GU cancer. Next slide, please. When it comes to treatment of renal cell carcinoma, we always say it's often spoiled for choice because of multiple reasons. And specifically, there are more agents which are available to treat. The landscape of renal cell carcinoma is evolving. There are more treatment pathways, the targeted pathways, which includes VEGF, PD-1, PD-L1, or mTOR inhibitors. And now we are, shifting more towards personalized treatment. And in today's session, we're going to highlight on how we need to personalize treatment in advanced renal cell carcinoma. Next slide, please. And these are the objectives of today's meeting. Okay, to bridge the global clinical evidence with Indian clinical realities in the management of advanced RCC. Also to explore the role of IO plus TKIs according to the risk stratification. Also collaborative clinical thinking because we're going to share certain cases which will help other doctors to relate their patients in certain scenarios. And treatment consideration in special population. There are different population within the renal cell carcinoma which need special attention, and that's what we're going to see. And finally, we're going to talk about focusing on improving quality of life, because the patients are living longer and quality of life is extremely important in these patients. With this context, now it's time to shift gears to our next important session, our keynote lecture for today on the topic of treatment of advanced renal cell carcinoma as per IMDC risk group, focusing on the ends of the spectrums. Yeah. May I request Dr. Pinanti, can you just mute yourself? Thank you so much, sir. Professor, first of all, thank you very much for accepting our invite to be the speaker for this topic. Professor Guillermo is a consultant medical oncologist at Hospital Universitario 12 de Octubre from Madrid. Professor is PhD in distinguished medical oncologist, focusing on GU cancers and melanoma. Professor has earned his degree from University of Madrid, and then he's also was associated with Dana-Farber Cancer Institute. He has more than 300 publications, and that's a huge number. In various clinical trials he was part of, and he played a very important role in shaping the ESMO clinical practice guidelines for renal cell carcinoma, contributing as co-author to the 2024 update. So that's a huge achievement to you, sir. And he's also active member of various multidisciplinary tumor boards and contributes to international oncology guidelines. So Professor, it's our privilege to have you with us for this meeting. With this, I would like to hand over session to you, Professor. You can start sharing the deck from your end.
So first of all, thank you so much for the nice invitation, and thank you so much for the presentations. I'm really humble. And okay, can you see my screen now?
Yes, Professor.
Okay,
we can
excellent.
See it.
Excellent. So as I was saying, thank you so much. And I have the honor to be discussing today about the treatment of advanced renal cell carcinoma. And I will be focusing in the IMDC risk group because I think that's our best tool these days to try to select better the treatment for our patients. So let's try to think a little bit about what has happened in the renal cell carcinoma in the last decade and how can we select better our treatment for our patients. So let's start thinking about the disease background in RCC. So first of all, there is something that every physician treating RCC should remember. First-line treatment remains an unmet medical need, but is the most important treatment for patients. Why is that? Because based on real-world experience, nearly half of advanced RCC do not go on additional treatment. That's really important. That's why it's so important to try to make the best choice for our patients in first line, because half of them won't get to the second line. Why is that? Some patients will have disease progression. Sometimes will have deterioration of the performance status. Some patients will have adverse events from this initial treatment. So that's why optimizing first-line treatment approach is a critical advance. So if we think about what's happening in the landscape, we have many drugs these days. So obviously in the left side of this figure, you can see all tyrosine kinase inhibitor targeting the vascular endothelial growth factor receptor, which is the key element to try to control the angiogenesis. So we learned from back in the 90s when was developed and was discovered that VHL was a suppressor gene. Since then, we've been focusing on targeting the angiogenesis. That's why all these tyrosine kinase inhibitor contribute to control the kidney cancer. But also we have different molecules such as everolimus, temsirolimus targeting the mTOR pathway, or the new immune checkpoints inhibitor targeting either PD-1, PD-L1, or CTLA-4. And finally, more recently, as you can see in the right side of the figure, there is belzutifan, which is targeting the HIF-2 alpha inhibitor. And finally, just to remind you that CAR T cells are on the way, and this year in ASCO have been presented data, really interesting data, with a new CAR T cell targeting CD70. We'll see what happens in the future. But definitely the evolving field of first-line treatment has been amazing. If you think what happened back in the 20s when we had only sunitinib upfront or beva plus interferon, the median before tyrosine kinase inhibitor, the median overall survival was 12 to 14 months. With tyrosine kinase inhibitor, we moved to a median overall survival about 20, 28 months. And now we are talking about nearly 48 months with double immune checkpoint blockade or with a combination of IO plus tyrosine kinase inhibitor. Definitely from those 13 months to 48 months, we're doing much better. But that's why we need to try to select the right treatment for the right patient. So individualized first-line therapy is needed. That's why. Why is that? Because we have so many options that we need to think carefully which is the best option for different patients. So first-line systemic therapy is recommended for all patients with stage 4. However, do not forget that some patients may still be okay with active surveillance. That's why it's important to differentiate those patients that will require a double immune checkpoint blockade, those patients receiving IO plus tyrosine kinase inhibitor, those patients even having just one treatment, or even some patients just being on active surveillance for a period of time. If you look at the timeline of first-line immune checkpoint-based combination options, you see here the data with nivolumab plus ipilimumab, FDA approval in 2018, and the last one, lenvatinib plus pembrolizumab, that was FDA approved in 2021. So at the end of the day, in only 5 years, we had 5 different immune checkpoint-based combinations approved by the FDA, either Ipi-Nivo, Axi-Pem, Axiavelu, Cavo-Nivo, or Lem-Pem. 2, that's important to remember, 2 combinations were using axitinib. So two different companies, two different phase 3 clinical trials thought that the best tyrosine kinase inhibitor to be combined was axitinib. Now, why is that? Because one of the good things about axitinib is yes, it's mainly targeting the vascular endothelial growth factor receptor 1, 2, 3, which is quite selective. So you are controlling the angiogenesis that we know to control with a kind of pure tyrosine kinase inhibitor. But obviously, when you are selecting the treatment for the first line, you need to think different points about your patients. You need to think about patient and disease factors, risk stratifications. It's really important, the comorbidities, also the histology or prior nephrectomy. Then we need to look into the efficacy data, the response rate, the CR rate, PFS, OS, or even the duration of response. Combining with the efficacy, it comes always what is the safety. And in this part, we need to think about immune-related adverse events. We know that with double immune checkpoint blockade, the number of immune-related adverse events will be higher, and obviously the non-immune-related adverse events. And finally, we need to think about other considerations. First of all, and probably one of the most important issues around the world, it's available options. What is the access to those different combinations, but also the dosing frequency and the quality of life. So let's try to think a little bit deeply into the Javelin Renal 101 phase 3 trial study of IO tyrosine kinase inhibitor, which is the phase 3 clinical trial with a combination of IO plus tyrosine kinase inhibitor with the longest follow-up. That is really important because now these days we're looking different data, and the longest we can be sure about how it's going to be those outcomes in the long term. So first of all, when you think about the use of Bavencio plus axitinib, the avelumab, we need to remember that one of the different things, the differentiations with avelumab, is that Bavencio has been shown to release the suppression on T-cell mediated anti-tumor immune response by blocking the interactions between PD and PD-1 receptor. Also, Bavencio has been shown to induce NK cell-mediated direct tumor cell lysis via aRCC, which is especially important. Why is that? Because we want to activate our immune system with these drugs. So we are doing in two different ways when you are using avelumab. First of all, because you are blocking PD-1 and PD-L1, which is the standard way, but what makes different avelumab from other immune checkpoint blockade is that you are even able to induce NK cell-mediated direct tumor cell lysis. And the lysis is really important because you will have more neoantigens, which may be able to be recognized by your immune system. And obviously, you are using axitinib, as I mentioned before. It's a pure vascular endothelial growth factor 1, 2, 3 implicated in angiogenesis, lymphogenesis, tumor growth, and cancer progression. So it's definitely in theory, just with the theory, it's an amazing combination of drugs. Obviously, we had to do this study, and that was a study led by my mentor, Tony Shueri, where 800 patients, nearly 900 patients, without treatment naive, were randomized 1-to-1 to receive either avelumab every 2 weeks plus axitinib, 5 milligrams orally twice a day, or the standard of care sunitinib. The endpoint, the primary endpoint, was PFS, OS for patients with PD-L1 positive tumor. This is important. And why is that? Because we know that PD-L1 is not the best predictive biomarker. We know that information now, not when the study was designed. That's first important information. And the second one, what we've learned about PD-L1 is that it's not predictive, but we know that it's prognostic, which means that those patients having PD-L1 positivity will have worse outcomes than those patients that are PD-L1 negative, and that's important. Now, think about this phase 3 clinical trial. And look at the follow-up durations for IO tyrosine kinase inhibitor. We've seen the data from the clear on the right side, 50 months follow-up. That's the last analysis for this study. For the CheckMate 9ER, 55, Keynote 426, 67. But for Javelin, we have the 73.8 months follow-up, which is quite amazing, more than 6 years on follow-up for these patients. So let's think about the populations included in the study, which is also very, very relevant, the Javelin Renal 101. More patients were intermediate, 61%. 21% had favorable, but 16% of the patients had poor IMDC risk criteria. Okay, with this longest follow-up, 73.7 months, higher median OS continue to separate till the end. This is really important because if we are not doing cross comparison trials, and we know that final OS readouts will better reflect the effects on later treatments, in this study, we don't see that there are a cross of the curves. However, in the other phase 3 clinical trials, we are seeing that those curves come together. So I don't know why is the explanation, but what I think is relevant that the median OS with axiavel was 45 months, with sunitinib 39 months. But if you see this hazard ratio, although it's 0.88, you see that there is a separation of the curve from the very beginning and that maintain with this longest follow-up. So this has been, so due to these factors, median PFS and response rate remains important endpoints. So if you look at this, a high proportion of patients in the sunitinib arm received subsequent PD-L1 inhibitor treatment, which is relevant. If you look at what was like the PD-1 or PD-L1 after sunitinib was 60% of the patients, which means like most patients got, we are comparing here axiavel compared with sunitinib followed by nivolumab, 60% of the patients. And despite that, we are seeing a really good results in terms of PFS, overall response, and overall survival. Okay, let's look at this median PFS benefit, which means hazard ratio 0.66, reduction in 34% of risk of progression when you are using axiavel compared with sunitinib. And I think when you're looking at this Kaplan-Meier curve, one of the most important points that you need to look is like when this curve can separate. If you look at the figure, it comes really during the first CT scan. So that's one of the issues why can you do sunitinib and follow by nivolumab, or it's better to go with axiavel. If you are starting with a combination of axiavel, you have an improvement of nearly 6 months of PFS, but the reductions in the risk of disease progression or death, 34%, starts from the very beginning. And that's why it's so important and so relevant for many of our patients to start with combinations instead of just tyrosine kinase inhibitor. And this data, which is quite relevant, now we've been using these combinations for many years, and that's why we need to look into the real world evidence to see whether the evidence is confirmed. And we need to look at the effectiveness and safety of the combination in our clinical practice. If you look at here, there are many data now coming from UK, from US, from Japan, when the data is really, really good in terms of median PFS, around 14 months in UK, 17 months in Japan. And which is quite relevant is like you're seeing kind of the same replication of median OS and the OS rates at 12 and 24 months, around 90, 84%, which means we are replicating the data from the phase 3 clinical trial, and we are putting that data in the real world, which is more important because now that many of our patients are not suitable for clinical trials. So avelumab plus axitinib has well-characterized safety and tolerability, and we know that most patients will have some adverse events with the treatment. But if you look at the patients discontinuing that they discontinue, avelumab was 29%, 19%, axi or sunitinib 12%, and all study drugs 4%. So most patients will have the options to continue until progressive disease that we know is really important. Obviously, when you're comparing avelumab or sunitinib, it's important to differentiate that patients on avelumab were 6 months more on treatment as compared with sunitinib, and that's important when you are seeing the adverse events because you are comparing patients that have been on treatment for 14 months with patients that have been on treatment for only 8 months. Obviously, we know that some specific adverse events are coming from the avelumab, and this is the infusion-related reaction of any grade, that is 29%. But we know that most of the infusion-related reactions are moderate to minor infusion reactions. So looking at the treatment-related adverse events, on the right side, sunitinib, on the left side, combination of axiavelo. It seems that most adverse events are common. So you will have diarrhea with sunitinib, you will have diarrhea with axitinib, you will have hypertension with both with a combination of tyrosine kinase inhibitor. So most of the adverse events coming from the tyrosine kinase inhibitors you will have with the combinations. But adding avelumab is not really giving you much more side effects as compared with just tyrosine kinase inhibitor. That's one of the ideas why, in my considerations, using combination upfront is pretty good, because you are using one combination that is offering you better outcomes, better PFS, better response rate, nearly overall survival, and it's not really adding much more adverse events to the drug that you really need to use for your patients. But I think, as I was saying at the beginning, advanced RCC is cluttered space. We have the IMDC criteria. We distinguish in patients with favorable, with intermediate, and poor risk patients. And we need to choose the right therapy for the right patients. And sometimes the IMDC may help to select the better treatment. Okay, let's look at the first-line IO combinations trials in metastatic RCC. One of the important things is like we're improving the outcomes compared with sunitinib. And if you look at the landmark OS at 12 months, with the checkmate 214, 83%, 90, 86, 90, 86, any combinations is giving you the landmark OS at 12 months around 86 to 90%, which is really amazing because we are basically increasing 10% as compared with monotherapy. But when overall survival curves are overlapping, the reality is like most combinations are giving you the same results. You see axiavelo on the top, but you see axipem, ipinivo. The reality is all these combinations are quite alike in terms of giving you the OS. So somehow we need to try to select how we can implement all these different combinations in our practice. What I was just saying at the beginning, this is a decreased magnitude of OS benefit over time shown for all phase 3 first-line IO tyrosine kinase inhibitor studies. Look at the checkmate, keynote, clear. They are coming together after 60 months of follow-up. So maybe selecting treatment across risk groups will be specifically or especially relevant. Let's focus now in the favorable. Which are these patients? So important. So patients favorable are those patients without any IMDC criteria, not hypercalcemia, not anemia, good performance status. They had an nephrectomy more than 12 months ago, and we need to think about using treatment. So that it's important because some of these patients with favorable IMDC criteria may not need treatment for a while. That's important. So some of these patients may be on surveillance for a long period of time. It's difficult to select these patients, but it's important to try to recognize which patients may get this. Also, in this favorable group, we may go for localized therapy. We may think about using SBRT, metastasectomy. So all these things make much more difficult to select which treatment for these patients. And it's important and even more relevant that these patients may live really many, many years. So making the wrong choice could be really, really bad for our patients. Indeed, we've seen now from the IMDC recently presented at ASCO last year, some even new classifications dividing the favorable risk and the very favorable risk. These very favorable risk are patients having nephrectomy more than 3 years ago, so the diagnosis more than 3 years ago, with a performance status of 90 or 100, so patients doing pretty well, and only lung metastasis. That's the very, very favorable. If you see this data, we've seen that response rate is as we could expect. In the favorable, 35% with ipi/nivo, IO tyrosine kinase inhibitor, 51%, 37% for tyrosine kinase inhibitor. But if you look at in the very favorable, ipi/nivo had only 23% of response rate and 60% with the combination of IO tyrosine kinase inhibitor. More important than that, looking at the OS in the favorable risk, there are no major difference with IO combinations or with tyrosine kinase inhibitor monotherapy. But in the very favorable risk, although this is a very small study, is retrospective data and only hypothesis generating, look at the data with ipi/nivo. Those patients receiving ipi/nivo in the very favorable risk were the patients doing worse during this study. So obviously, for those patients that were supposed to be living for many, many years, trying to select the treatment that can do less harm could maybe more important than just treating patients. So in conclusion for this IMDC study, there was no significant difference in 2 years OS. However, IO tyrosine kinase inhibitor had better outcomes compared to tyrosine kinase inhibitor in terms of overall response rate, duration of treatment, and time to the next line. This is what we've seen also in the phase 3 clinical trials. Even more important than that, in the very favorable risk subgroup, there was a statistically significant decrease. Remember, decrease in 2 years OS and response rate with ipi/nivo. So when you're gonna think about favorable, we have included that ipi/nivo in the ESMO guidelines for favorable, but please be careful about favorable and very favorable risk subgroup. Obviously, we need to think about longer follow-up and more patients included in this type of study. So, unclear OS benefit was shown in the phase 3, as we were saying, but look at what happened in the Javelin bladder. The favorable IMDC risk group showed benefit when treated with IO tyrosine kinase inhibitor compared with tyrosine kinase inhibitor alone, and this is real-world evidence from UK. Look at this data. IO tyrosine kinase inhibitor plus immunotherapy compared with tyrosine kinase inhibitor has a ratio 0.42, which is really, really amazing for overall survival. And the PFS benefit as well, 25 months compared with 14 months when you are using combination of IO tyrosine kinase inhibitor. So definitely, this is data more positive thinking in real-world evidence. Okay, let's look at all the landscape, all the different combinations axia value. If you look at the data for favorable risk group, this is cross-trial comparisons. We need to be careful about doing over-interpretation of this data. But if you look at the OS hazard ratio in the favorable, with axia value is hazard ratio 0.7. In the keynote, axi-pembro 1.1, cavo-nivo 1.1, len-pem 0.94. And the response rate was the highest with the combination of axia value, 67%. And if you look at the comparator that was sunitinib, that was quite the same. 46 in the axia value, 50% in pembro, cavo-nivo 44, len-pem 50. So we have the same comparator, and what we have seen highest response rate and better OS is with the combination of axi plus avelumab. And just let's move to the other side of the IMDC risk group. What's happening with the poor IMDC score? So again, in the Javelin renal, it's quite striking that the combination of axi plus avelumab did amazingly well with the combination of axi plus avelu. Hazard ratio 0.50. So we are doubling our PFS when you are using axi avelu compared with sunitinib. 11 compared with 21.3 months PFS. This is quite amazing for patients with poor IMDC. And also, when you look at the stratify hazard ratio 0.48. So let's go back to the first-line IO combinations trials. As I was saying, this is cross-trials comparisons. It is not something that you can go straight to say this is better based on the data. But when you're looking in the indirect data, for favorable, hazard ratio 0.73 for favorable. For poor, look at what happened in the median overall survival with the ipi-nivo 0.69, really important, really good. Keynote, axipem 0.67, cavo-nivo 0.63, lempem 0.64, but axiavelu did again has a ratio 0.58. It's again quite amazing data for these specific poor patients. So selecting treatment across risk groups, obviously for, as I was saying at the beginning, favorable. You could do active surveillance for those patients that they have an indolent disease. You could think about using tyrosine kinase inhibitor alone, but in my opinion, in most cases, when you're gonna treat your patients, treat with your best choice, because as I said at the beginning, patients may not get to the second line. That's why patients starting on AX and on treatment first line, favorable, I would be more inclined to use a combination with IO tyrosine kinase inhibitor, and axiabelu these days with this data seems quite powerful to think about it. For intermediate, we have different combinations, nivo, ipi, lempem, cavo, nivo, but definitely when you are thinking again in the patients with poor prognosis, ipi-nivo may be a very good option, but if you are thinking about you need a response rate, lempem, axipem, cabo-nivo are options, but as I review, axiavelo has also really good data to support the use of these combinations in patients with poor IMDC criteria. Obviously, in advanced aRCC, patients are living longer, hence safety, quality of life, it's even more important. So we need to try to make sure that our patients are living longer, but they are living better. As I was saying, 12 months OS rate, 83, 86, 90%. Let's think now about treatment-related adverse events. When you look at the grade 3 treatment-related adverse events, grade 3 or higher, the combination of IO plus tyrosine kinase inhibitor with better data are the combination of axiavelo, 57 compared with 61 with lempem, 67 with axipen, or 65 with cavo-nivo. Obviously, there is 46% with ipi-nivo, but in this case, all of them are immune-related adverse events grade 3, which may be more complicated. And also, the discontinuation of both drugs due to treatment adverse events is really high, it's really low, only 4.8 months. And that was the combinations with lower use of steroid use. Maybe the use of treatment every 15 days may be more tolerable, or at least controlling better the immune-related adverse events. Looking at the quality of life and health-related quality of life during the study with patient-reported outcomes, there is definitely, we cannot say that is an improvement compared with sunitinib, but definitely there is not a deterioration of the quality of life during the treatment, because in both, either with sunitinib or axiavelo, there was an increase in the quality of life. So what is your preferred tyrosine kinase inhibitor with IO? Obviously, you could think about all these tyrosine kinase inhibitor may have a specific role. Cabozantinib is a pretty good drug because it's blocking MET and AXL. Lenvatinib has this action against FGFR that may be quite relevant. Axitinib has something pretty good. First of all is the plasma half-life. So axitinib reaches a stable level within 2-3 days of initial dose, but the short half-life of Faxi makes the management easier than other drugs, because you stop the drug and basically the adverse event disappears quite fast. This is good when you're using different combinations of drugs, IO plus tyrosine kinase inhibitor. You don't know which drug is causing the side effects, such as diarrhea. So you stop the axitinib and you see whether the diarrhea is being controlled or not very rapidly. And obviously, IO plus tyrosine kinase inhibitor has overlapping toxicity, as I was saying, hepatitis, diarrhea, hypertension, arthritis. So all these overlapping toxicities may be controlled easily when you're using axitinib, because as soon as you stop treatment, you will see an improvement with the tyrosine, without the tyrosine kinase inhibitor. So avelumab plus axitinib, we have also data in a specific subgroup of patients, elderly, sarcomatoid, patients undergoing dialysis, or even for acute kidney injury and pneumonitis. So first of all, so we know that some of our patients, 10, 15 of patients will be higher than 75. We've seen is like the response rate in patients higher than 75, it's about the same that in the overall population. So we'll still see that patients, all the patients may do pretty well in combinations with IO plus tyrosine kinase inhibitor. Secondly, we know that when it comes to sarcomatoid, you need to think always with the combination of ipi/nivo. That is the first choice for most patients with sarcomatoid differentiations because the data with ipi/nivo is really robust. So that should be, at least in my opinion, your first choice for patients with metastatic RCC and sarcomatoid component. However, the combination of Axia-Velu has shown also clinically benefit in patients with sarcomatoid RCC. And that could be something to consider for those patients that require a response really fast, and you may be a little bit worried about losing your patients because really needs a response, and with ipi/nivo it may be delayed or you may not get the response that you want. So occasionally for those patients really requiring a response, this could be also a good combination in this specific population. And just coming to the end, I guess the use of Avelo plus Axi for the treatment of end-stage renal disease in dialysis patients, we have already data here. So if you have a patient with really bad situations with a papillary RCC type 2 with or acquired kidney disease or patients with dialysis, there is already data showing that Axi plus avelumab could be one of the options that can be used. And also, for patients, we know one of the issues that we have with in general, with all treatments for patients with RCC is that they have nephrectomy. So they have just one single kidney. Some of them may have even a second primary tumor or kidney metastasis. So the kidney function is really important for our patients. We are using tyrosine kinase inhibitor for many years. We know that the immune checkpoint inhibitors may conduce to acute kidney injury. So if we are thinking about which is the checkpoint inhibitor that may show better or lower acute kidney injury, one of the immune checkpoints is avelumab. So that's why it could be another reasons to think about using avelumab for patients with metastatic RCC. And finally, although pneumonitis is very uncommon for patients with metastatic RCC, when you look at data from meta-analysis, avelumab seems to be one of the PD-L1 inhibitors or immune checkpoint inhibitors producing less pneumonitis. So in summary, for this keynote lecture, advanced RCC treatment, selecting the right therapy is crucial. I always remember this to physicians treating metastatic RCC. There are other diseases when you can be more relaxed about selecting the first line because you can recover your patients. This is not about kidney. So when you are seeing your patients with metastatic RCC, the first day in your clinic, making the choice, you may need a couple of days, you may need a week, but think carefully which is the best option for your patient, because could be the first treatment and the last treatment for that patient. Favorable risk group, IO combinations are suitable. If you are going to treat your patients, I think it's better with a combo. And Avelo-Axi has shown a really good hazard ratio and even better compared with other IO tyrosine kinase inhibitor. So it could be a really good and reasonable option for your patients. IMDC poor risk groups, Avelo-Axi, 42% reductions in the risk of death, really good data. And the safety, critical due to long-term durations. And Avelo plus Axi has lower discontinuation, steroid use, and better pulmonary safety. And obviously, when you're looking at these subgroups, we have data on patients undergoing dialysis, acute kidney injury, elderly patients, and even for those patients not being able to receive ipi/nivo, we have really good data for sarcomatoid components. So definitely, Avelo-Axi strikes a really good balance between safety and efficacy. Thank you very much, and happy to take any questions during the discussion.
Thank you so much, Professor Guillermo, for an insightful talk. As of now, we don't have questions, but I'll definitely update you if there's any. Also, in the meantime, we have our chairperson joining us for today, Dr. Amit Joshi, sir. So I would like to invite him to address the forum.
Yeah,
Uh,
so I thank you and sorry for I got caught up in a meeting in the hospital. So I think the talk which was given by the distinguished speaker, I think it has just opened a new aspect of the, at least for the favorable risk RCC. And I think we definitely have learned some new things today, and our perspective for looking towards the good risk RCC, where we feel that only TKI is there. So I think definitely we will um, 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 look to the management of a at least the favorable risk RCC in a different way. And it was a very nice scientific presentation. And we should thank the distinguished speaker and the Merck for arranging this talk. So I think we'll continue with the planned session of that. I may have to leave for another some personal, so I may leave the meeting, and I will again thank everyone for joining this meeting. I may try to join for this panel discussion till the time I am not caught up in another issue. Thank you everyone.
Thank you so much, sir. So now we move ahead with the next session, which is by Dr. Akhil Kapoor, sir, on an Indian case study of RCC. But before that, I would like to introduce Dr. Akhil Kapoor, sir. Can we move to the, yes. So Dr. Akhil Kapoor, sir, is a professor from Tata Memorial Hospital, Varanasi, and he has an extensive experience in the management of solid tumor. He's also on the board for molecular tumor and rare tumor. He has completed his DM from Tata Memorial Center in Mumbai, and he's known for his patient-centric approach, and he's deeply engaged in the academic research and also has several publications on his name. And similarly, he also contributes to the oncology education and awareness across the region. So, sir, we are honored to have you today, and I would like to pass on the session to you. Thank you.
Thank you. Thank you to the team, and thanks to the professor for a very detailed and useful presentation. My job is to give a case summary of a patient who has been treated with Bevacizumab plus Axitinib. And yes, as we have seen, selecting the patients and also the quality of life remains the key, because we might have drugs like cabozantinib, drugs like lenvatinib, but the problem is that whether it is well tolerated, and especially in our settings where we see a lot of toxicities in our patients with these multikinase TKIs which are there. So if we can use TKIs like axitinib, which are known to have much milder toxicities, it's much good enough, because our patients will have good quality of life and tolerance to the treatment. So that is what is desired from a first-line regimen, at least in these advanced cancers. So yes, coming back to the case, this is a 69-year-old lady, and as we know, geriatric oncology is very important now. So this case was discussed in our geriatric clinic in our hospital. The patient is actually was treated with for RCC in 2019. IMDC was poor risk actually. Patient has also undergone a surgery for knee replacement. Also, she had comorbidity of ejection fraction of just 35%. Besides hypertension, adrenal insufficiency, multiple comorbidities. So yes, such type of patients require a multidisciplinary approach, incorporation of your cardiologist and your physician team, especially if feasible. So that was done in our geriatric oncology clinic. Patient was diagnosed to have a recurrent and metastatic disease, and the patient has presented with backache and pain in the right flank. This is the scan which was available. You can see in the CT scan, there is a large mass which is coming there, and there is a deposit at the scapula, acromion process of the scapula. So this is the problematic area. Patient have a significantly symptomatic for pain, and the patient had a compressing thecal sac as well. So the patient was treated with radiation as well, and patient was started on denosumab, and finally the patient was started on avelumab plus axitinib treatment. So this avelumab plus axitinib was considered because we did not want to utilize drugs like lenvatinib, drugs like cabozantinib, as I highlighted, because they are known to have very strong activity and toxicity profile, and especially when ejection fraction had been low previously, though it had improved to the tune of 45% and above when we started this treatment of avelumab plus axitinib, and cardio-oncology clinic consultation was also taken at the hospital. So with the careful monitoring, we started the patient on avelumab axitinib. The initial scan, you can see it was seemingly stable disease after 4 cycles. A further scan showed some amount of mild increase in uptake, but that was considered as a pseudo progression because patient had significant improvement in the symptoms. And it also showed, on closely looking at the scans and discussing with radiologists, showed a lot of necrosis inside the tumor. So this is a very important part, especially in lungs and large lesions. We can get a large amount of necrosis leading to pseudo progression, because that will lead to increase in the size. But at the same time, the patient is having symptomatic benefit. That's the reason we continue treatment for this patient. Now, what happened later on in the subsequent scans, you can see the lesion is shrinking in size, the uptake is also reduced, and the drug is actually working. So the patient has now achieved 30 months of progression-free survival, and that lesion has in fact gone below 50% of the initial size, and that patient is now doing well. And that patient has now completed 60 cycles of avelumab 800 milligram plus axitinib. Now we were thinking whether we can stop at least avelumab now, because we know there is an option of stopping immunotherapy after a duration of around 2 years. Here the patient is doing well. There's no hardcore data of stopping, but yes, if what happens, patient might be fatigued of visiting the hospital every 2 weeks. That is why the patient is considering stopping the treatment, and we have given an option for closer follow-up and continuing axitinib 5 mg milligram BD. At the same time, the patient is on close follow-up for proteinuria, because though axitinib doesn't cause strong proteinuria, but there are some chances that because the patient has been multiple comorbidities, diabetes, also cardiac complications, the patient might end up having an increased amount of nephropathy. Component of both diabetes and TKI might be there. So urine albumin creatinine ratios, USER, which is very commonly done in our practice. And when USER seems to be alarming, we try to do 24-hour urine protein to see that. So yes, if this is a perfect example of a case where we utilized treatment like avelumab plus axitinib, and the patient has responded very well, despite the location of the tumor being very challenging and highly symptomatic lesion at the baseline. But thankfully, with the involvement of the multiple teams, radiation, utilization of denosumab, and at the same time, immunotherapy plus TKI combination, which is one of the most tolerated combination available, the patient has done well till now, despite having multiple comorbidity. And yes, the patient is doing well. Let's hope the patient continues to do well for longer duration. With this, I would love to stop here, and we can have further discussions.
So may I ask you, so you know that we've been doing a consensus because it's not clear, but I just want to mention that in the recent consensus that we've been doing with, and it's not exactly the same people from the ESMO guidelines, but we are kind of a good representation, and we have recommended not use PET-CT scan or in general for aRCC, because the data, there are like between false positive and false negative data. We have recommended that we do not recommend use the PET-CT scan for most patients with metastatic RCC. In this case, was pretty nice and was pretty clear, and that's good and has been really good. But just in case, the recommendation is that for most patients with RCC, just do CT scan. And this that just more a comment. So it's not like it's bad, but the recommendation is trying to do just CT scan. And the second is, have you thought about using SBRT for that lesion within the bone?
Yeah, so these are very two important relevant points. First point is about PET-CT. So in our country, actually, PET-CT scan cost is nearly similar to CCT thorax abdo-pelvis. I completely agree. When PET-CT is more costly or requires more resources, we always try to utilize CT scan. But yes, PET CT scan is usually one-stop solution most of the time because it gives better idea about the bones as well. But yes, I agree in clear cell RCC and most of other RCCs, and the PET CT doesn't have any much extra information. So CT is also a good enough option. So I completely agree with you. Regarding SBRT, yes, this patient, when the lesion was initially very large, actually, the lesion was to the tune of crossing 5.5 centimeter, and that was very close to spine because the spinal neural foramen was compressed actually. So in this scenario, our radiation oncologist suggested that SBRT might not be safe enough. And now, when there is a very reduction in the tumor composition and the lesion is now somewhat far from the spinal component, I think it makes sense to consider again option of irradiating it with SBRT. Patient had previously received a dose of radiation that was palliative dose of radiation that was 30 grain 10 fractions, but SBRT was not considered because spine was very yes, you can see in the images, spine was very close to the lesion. And
especially for this patient that has been on treatment for 30 months, and if you want to have a break, that could be the most dangerous lesions. Like if you go for SBRT and you have a break, that could be something that to think about.
Correct. Completely agree. So that's
a great case.
Yeah. Thank you, Professor.
Thank you so much, Dr. Akhil Kapoor, sir, for sharing such an interesting case with us.
Dr. Akhil, yeah, may I interrupt you?
Yeah.
Gupta.
Yes,
Actually,
sure,
I
sir.
was just looking at the PET CT scans images. The Excel images, just they were showing almost 25% of the tumor is going to the spinal canal, right? And it was in the very critical location.
Correct.
So in our setting, I guess the patient must have radiculopathy or some neurological symptom.
Yeah.
So sometimes this kind of the patient may require urgent decompression and fixation with the surgical measures. So, and after that, RT will be the important modality to treat the local tumor. So this is my point actually.
Yeah, completely agree. Multi-spine involvement in this patient was the reason the patient was not considered.
Yeah, but actually we couldn't see the sagittal images.
Yeah.
So the image you projected is very critical and critical narrowing at that point. So that might be the surgical fixation may be required in this patient if patient is much symptomatic and not responded to the initial treatment. Because you see the available also works little slower and excitinib also. The median time to having the effect, the onset of the symptomatic relief is almost 8 weeks.
Yeah,
So
definitely.
sometimes it might be the case.
Yeah, I completely agree with you, sir. And that is why in such a cases where it is seemingly important, this patient had some radiculopathy symptoms. So an aggressive consultation from our BST oncology team was also taken. But yes, as the lesion was multi-vertebral, it was not confined to one vertebra. Our team suggested that might not give the best possible support because the lesion was, if we see the sagittal section, the lesion was extending to close to 9 to 10 centimeter, making it very difficult to provide supportive. So the patient was treated with radiation. At the same time, the patient was immobilized for around 17 to 20 days actually.
Yeah. And the other thing, one point is the RCC is known to be radio resistant at the primary site. But once it goes to the bones and other sites, they are radio sensitive. So there might be the good response if you require RT anytime. Yeah. So you may proceed further. Yeah. Thank you.
Thank you for the comments.
Thank you so much for a good discussion. Now we move into the next part of today's session, which is the panel discussion. IO plus TKI, taking a close look into favorable and poor risk group. And I would now like to invite our moderator, Dr. M.V. Chandrakant, sir. Can we move further? Yes. So Dr. M.V. Chandrakant, sir, is an academic head at Naragna Group of Hospitals in Kolkata. He's had over 22 years of experience, and he also specializes in managing solid tumor hematological malignancies with expertise in breast, lung, GI, GU, and lymphomas. Doctor is also has been known for evidence-based approach and patient-centric care. Now, I would like to pass on this to Dr. M.V. Chandrakant, sir. Over to you, sir.
Thank you, Juhi, for that kind introduction, and it was wonderful hearing Professor Guillermo and also Dr. Akhil. A lot of learning. So let's quickly go through the panel discussion. Can I just share my slides in the meantime?
Yes, please.
You unshare this, and I'm going to share it. Yeah. So the panelists, I think, are there. So we have the professor, Dr. Guillermo, and then we have Dr. Akhil, Dr. Asim, Dr. Arun, and Dr. Anand. All four of them start from A, and therefore it comes in that alphabetical order. And then we have Dr. Burhan from B and Dr. Rakesh from R. So that is the alphabetical order we have. I was just looking that, like 60% of them have the name starting from A. Right? So is it visible?
Yes, sir.
Right. So it is just a revision of what Professor presented and how to take it to clinical practice. So I will be going in the same order as per the alphabets, and I will be requesting Professor to give his inputs whenever he feels apt. Right. So we all know that there are some diseases where there are no choices. Like let's say pancreatic cancer, we don't know what to do after 1 or 2 lines of treatment. Whereas here you have plenty of choices. So having a lot of choices is also a challenge, and all of them being indicated in the same space. So let me start with okay, Dr. Akhil just finished the talk. Let me start, Dr. Asim. So Dr. Asim, let me request you for this question. So let's say an advanced kidney cancer is sitting in front of you. So how do you think, what are the things that come into your mind before you offer? And of course, finance and what scheme the patient is, that is the first thing that comes into the mind in India, rather than the financial aspects. Okay. So what comes into your mind clinically when you start treating this patient?
Yeah, so Dr. Chandrakant, actually, this patient was, I guess, 69-year-old lady with the poor LV ejection fraction of 35%, right?
No, there's no case.
Okay, but you are asking in general.
There's no case. It's just I'm just saying you. I think you are recalling a case that you. Okay, the previous one you just.
I think it is a continuation of the previous case, but still.
Oh, right.
Yeah,
no,
no
this is a
no
panel discussion. There is no case.
Okay, no case support is exempt. Actually, how do I proceed in the treatment? So, firstly, you divide the patient in the according to the IMDC criteria: poor risk, good risk, and the intermediate risk. So, poor risk, we are very clear. We need to give combination whether it is IO or IO plus TKI, and we have used all sort of combination len pembro and nivo ep, and now after this talk we might use IV and XC also, and pembro XC also we have used. So all of them have actually remarkable effect on the patient's life. But sometimes what I feel is, if patient has some crucial symptom at the presentation, like patient have some pleural effusion, like patient have some kind of bony pain, or some triggering symptom which needs urgent attention, then my choice is to involve TKI somehow, because I feel the immunotherapy is little later to relieve the symptom as compared to the TKI. So TKI based combination I take in front. But if suppose patient is not symptomatic and they are still coming into the risk group, poor risk or intermediate risk, then I will choose between the IO or IO-XC. So most of the time I go with the Nivo EP and Pembro XC. And Lenva has a good data in survival, but the problem is that much dose of lenvatinib is tough to give in our setting. So a little bit it is lower. And honestly speaking, we have tried the cosmic data also, Nivo EP and cabozantinib in combination. So this is my take. And Pembro, yeah, and Pembro after this today's talk, it seems promising, and tolerance wise is also good. So I might try AVXC also.
Right, very good. So you clearly stated that IMDC risk stratification is a compulsory exercise that we must do before we treat any metastatic RCC. Okay, so there are some nuances in this IMDC. This is just reflecting the disease burden, that is the quantity and the pace of the disease. But the site of metastasis is not yet there in this, whether there are multiple liver metastasis, whether there is a brain metastasis, this is not there. So let me request Professor Guillermo. So apologies if I'm not able to pronounce your name properly. It's so brain metastasis, liver metastasis, bone only metastasis. So do you look at the site of metastasis also as a marker for choosing anti-cancer therapy?
Yeah, so this is a really very good point. And where we need to remember is that site of metastasis by itself has an important prognosis, which means that there was a very nice data from the IMDC that I was part of, that we looked specifically at only patients with 1 by 1 site of metastasis. And when we learned from that seminal paper is that there are patients with pancreatic lesions that are with patients with pancreatic metastasis are the patients with better outcomes, which means like if you have a patient with IMDC and only pancreatic lesions, you may think about active surveillance, not even SBRT or systemic therapy, because those patients will be very for many years they can remain on active surveillance. Indeed, one of my patients has been on active surveillance. I started long time ago with tyrosine kinase inhibitor, but then I thought when I learned about this data, I said, okay, let's stop. And she has been on surveillance for the last 7 years without progressive disease. So that's something that we need to remember. And obviously, in the other side, there were patients with peritoneal disease, there were patients with brain mets, and there were patients with bone mets. So those patients are different. So obviously, if you have patients with brain mets, I would be very cautious about, even if the patient has IMDC good prognosis, I would be very cautious about doing active surveillance. Definitely, I think we need to be much more active for that. So definitely the location of metastasis is going to be quite relevant for patients with advanced RCC. So the IMDC is good, but obviously we have more things to think about beyond the IMDC criteria. And definitely location of metastasis are really relevant. So for brain mets, I haven't discussed anything for brain mets, but the drug that we have more information in brain mets is with Cabo, single agent and with combinations. But specifically with single agent, cabozantinib has much more data built on metastatic RCC. So patients progressing with IO, for example, Axiavel within the brain, which is more common in second or third lines. So the option would be to go for cabozantinib monotherapy.
Thank you for those precious points. Pancreatic mets, good prognosis. Brain mets, Cabo is preferred. These are the 2 learning points for today. Right.
Hey, Chandrakant,
Yes,
what,
Dr. Asim.
I wish to make few points. I agree with the professor, and I also feel that some sites of the mets are different than the other in the renal cell cancer. And once you treat the brain mets patient in the renal cell cancer with cabozantinib, so it is like you are treating HER2 positive disease with the trastuzumab. And what we have learned over the years is you first give 1 or 2 years of Nivo EP or some combination, and then you need to continue with the Nivo Cabo or Cabo alone. So I remember 2 patients, actually 3, but 1 is lost to follow-up. But 2 patients of mine, they are surviving for at least 4 years with the cabozantinib with the brain mets, and they came after the surgery in the bedridden position for 2 months. And now they are good in calculation, their brain, sensorium, everything, cognition is normal, absolutely normal. So cabozantinib is one drug which can be utilized for the brain mets, in symptomatic brain mets, and the infusion.
Cabozantinib is brain mets. Excellent point, sir.
And infusions. Wherever is the infusion, you need to apply this.
Right. Thank you. So thanks, Dr. Asim. Thanks, Professor. Dr. Arun, you can take it up. So in Indian setting, good, intermediate, and favor, and poor prognosis. What is the percentage distribution?
So in my practice, and moreover, in all Indian neighborhood, I believe the poor risk and intermediate risk are numerically high. The favorable risk will be very less, maybe 5 to 10% only.
So a rough distribution, let's say 15,
Maybe
10 to
15, sir.
15, 40,
Yeah,
and 40,
10
something
to
like
10 to
that.
20%. 10 to 20% will be the favorable risk. Rest of things, if you calculate as per IMDC, so 1 to 2 points definitely will be there.
Intermediate risk is a big chunk, right?
Big chunk,
So
big chunk.
the Western literature, the intermediate risk is following a huge chunk. But in my Indian experience, I do feel that good number of patients come into poor risk category. So we have delayed presentation, we have heavy disease burden, we have a poorer performance status. So therefore, they automatically qualify for a poor risk. That is what I have seen. Like the time from diagnosis to treatment is usually less than 1 year. That is one. Performance status is usually 1 to 2. That is one more where I am going to qualify. And number 3, hemoglobin will be invariably low. So they invariably qualify for poor risk in our patient. Like it's something like 30% and above. That is a number in our setting. Right. So let me go further. So this is what we learned from professor's presentation. So many options, but we can't give everything to everyone. We need to have some strategic placement to use in different scenarios. And this we already saw as per ASCO recommendation. So let me ask Dr. Anand. Dr. Anand, this is what is there as per the ASCO recommendation. Intermediate poor risk IO TKI, favorable risk IO TKI, who require systemic therapy, favorable risk with comorbidities, that you have monotherapy with TKI. Do you agree with this, Dr. Anand?
Yeah, I think partly we are correct with what we are seeing in the guidelines. So for those patients who are technically eligible for a combination therapy, who have got a good PS, age is not a bar, cardiac status is good, polypharmacy is not there, drug interactions to be checked. So these patients, I think, so can go for a combination. But yes, those with this subtle what we would call as relative contraindications or points to remember when you treat this advanced RCCs. I think so single agent therapy is not a bad choice. I have given single agent TKIs also in the favorable subgroup, and like Professor had said, and Dr. Asim had also said, those with brain mets do well with cabozantinib. So I think somewhere single agent TKI is, we have all seen over many years that we have used single agent TKI, whether it was
Right.
sunitinib and azacitidine also. So somewhere I feel there is role for
Right,
single agent
right.
TKI, but I would err on the side of giving IO TKI even in probably the favorable subgroup. So I think kind of agree with what is written there.
Right. Thank you. So just in continuation with that, Dr. Anand, there are various IO-TKI regimens available, and you can clearly see that if you are focusing on the favorable risk, either pembrolizumab with axitinib or pembrolizumab or nivo-cabo, you can clearly see the hazard ratio is crossing 1. It's not even within unity. So it's 0.94, and it is crossing 1. So clearly, we should be careful when you're looking into the favorable risk group, and you cannot just throw your options of IO-TKI in these patients because it's
Yes,
crossing
agree.
unity. This is one,
Yeah,
and then go to the this is what you should be careful before you offer IO-TKI, and this is the data I think professor was presenting. This is the favorable IMDC risk group in a large UK real world data. And you can clearly see that 95% of them received aRCC as the IO-TKI of choice. And you can see the overall survival hazard ratio is 0.42 for overall survival. And for progression-free survival, it is 0.6. So you can see the median PFS almost crossing 2 years and the overall survival around 41 months. This is a phenomenal separation that you can see in contrast to the other IO-TKI combinations. Right. So we have the staggering data. This is the curve suggesting that the hazard ratio in the favorable risk with other IO-TKI combination is 0.9 to 1 to 1.1. And this is the curve clearly showing the separation, with the hazard ratios being impressive, like 0.4 and 0.6. And let me now go to Dr. Burhan. Dr. Burhan, there we go. You saw both the data sets of IOTKIs, 3 curves not significant and couple of curves with away axis showing significance. So what is your impression after looking at these curves?
So what I actually feel is that out of all these IO with the TKIs, I think the XE with the Exatinib has shown the maximum sort of a benefit as far as the OS benefit is concerned. So I am actually off late. We have been using a lot of this thing Exatinib with
Avelumab.
Avelumab. That has been my off late. In some of the patients I have started. Not previously. I think we were using more of the single agent. You can say the TKIs in the favorable risk, not the IO. But since we know that off late for the IO as well, like nivolumab and for the Pembro, we had the patient assistance program coming up. So we are actually counseling now some of the patient. But the problem that I feel is the data is not so convincing as far as the other IOs are concerned. So that is precisely my actually I would like to have one of the questions from with the professor. So why did you how you feel that the other IOs are not doing well and the avelumab is doing good as far as the favorable risk is concerned? So what is his take on this?
So Professor, just to reiterate, very important question. All our practitioners in India have favorable risk, excellent data, tolerance, fantastic. ITT population, no OS benefit. Pemroaxi, we are happy. There is an approval, category 1. Similarly, whatever, Nivo-Cabo, Pembro, Lenva, there is a OS benefit, but they're not showing benefit in favorable group. But the ITT is showing benefit. So this block of ITT not showing that statistical significance. So how do you overcome this among the practitioners in India?
Yeah, I guess we need to differentiate a couple of things. So when the study is designed, the methodology is planned to show a benefit in the overall population. So, and obviously when you have the study design and you think, okay, let's focus on the ITT population and this is positive. One of the difference that may cause that we didn't see in the ITT population for the Javelin was that the OS was for PD-L1 positive, which, as I mentioned at the beginning, we are somehow selecting patients with different prognosis, and they also may affect. So that was what I mean at the end of the day was in the line. Is this because this is better? Well, we are using AXI, and then we are using Avelumab, which is another PD-L1. So I think it's more about, you know, your chances to be positive or negative, that you have also some factors that you don't control in general, okay? Said that, now let's think about what's happening in the favorable. So in the favorable, because we are obviously selecting only 15-20% of the patients with better prognosis, if you are thinking how many patients you will need to include to show the benefit, probably you need to increase that number for like by 100. You need to multiply the numbers. Like if there were 900 patients in one of those studies and there are 200 with favorable, you will need to have 2,000 and 10 years of follow-up to see the difference. That's why it's very difficult to think of that. Saying that, now with the data with Axiavelu, there are sometimes when you are analyzing data, there are some factors that you don't control, and whatever is the reason, Axiavelu is performing pretty well in that population. So now is when you need to think, this is just hypothesis generating, but that makes sense. And then you think, okay, Axi is working pretty well. What's the difference between Axi and PEM? So then you say, well, Avelu is being used every 2 weeks. The tolerance is better. There is lower number of discontinuations. That could be the reason why you are seeing the benefit in that specific populations. But obviously, you don't have like an absolute data to prove it, because as you mentioned, the study was negative. Said that, when you have all this data and you are seeing the hazard ratio 0.7, it's like, wow, we moved in the ESMO guidelines, we included Pinivo because the hazard ratio moved to 0.7, 0.8. And then you're seeing, okay, I have a hazard ratio 0.7 for OS in the favorable. Do I believe on that? I do.
Right. So I think Professor communicated very clearly. In the first line setting, there should be an excellent balance of benefit toxicity. The benefit should be outweighing a toxicity in the first line favorable setting. If you have lenvatinib at 20 milligrams or cabozantinib at 40 milligrams, the toxicity is little concerning, and probably that is the reason why it is crossing the confidence interval. So we should be careful in giving our good IO-TKI combination, which is safe and also equally effective. So probably that is a reason what Professor was hinting towards as to the rationale for using this aRCC combination in the favorable subgroup. And there you go on the screen, you can see how favorable risk is a different biological subset. So these IMDC risk stratification is not just a mathematical calculation, it is a way of classifying them into three different biological subgroups. Especially a favorable group is completely different when compared to intermediate and poor. And that is why you would see an IO doesn't benefit in favorable group at all. The label is not at all there. So it's not just a scoring, but it's a different biology, and you need to have a strategical choice for addressing this favorable group, and that is what there is there on the screen. And then let me just quickly continue. We have more to discuss. So this we discussed. So favorable group aRCC looks outstanding. And now coming on to poor risk group. So as I was saying, we have a greater number of poor risk patients than intermediate. I mean than that is there in the Western literature. So when we were doing a phase 4 trial of Nivo EP, poor risk were like 60% of them were poor risk in our hospital. So we have delayed presentation, poorer performance status, and lower hemoglobin levels, and that is why you have this. And poor risk doesn't do well and needs to be addressed again. And this is how in the poor risk group, aRCC is doing extremely well again. You can see the progression-free interval, the delta, and also the overall survival is again better, almost doubling of overall survival. And you can see an early separation of curves. Let's focus on this poor risk group. Hazard ratio is extremely impressive, 0.58 vis-a-vis others. So let me go to Dr. Rakesh. Dr. Rakesh, there you go. You saw both favorable risk and also poor risk. The hazard ratios are phenomenal, and it is far better than the other existing IO-TKIs. So how would you look at this data, and can you take this data to your clinical practice?
Yeah, I think this is a practical approach to both favorable as well as poor risk. If you look at favorable, we have the option of single agent TKI, but practically speaking, not many patients can go on to second line and take the immunotherapy. So we lose upon the opportunity of taking the immunotherapy. And looking at the data, which has good hazards for the favorable risk group as well, in the AXI and Adalimumab does give us an option of exposing the patient to immunotherapy in the favorable use. Coming to the poor risk, again, the lenvatinib plus pembrolizumab is not practical because of the dosing of lenvatinib, especially for the Indian patients. And cabozantinib could also be a bit tough physiologically for the patients. So even in that regard, the safety-wise, I think the AXI and adalimumab does approach to be a very practical option for our patients. I do have an experience of treating patients with AVE and exitinib in the favorable risk as well as in the poor risk. And it also comes with a favorable risk profile of stopping the exitinib and understanding the toxicities, which is a contributing factor to the toxicities. So I think it is a one-stop go for both the high risk as well as the intermediate risk, as well as for the poor risk as well. With the combination having good safety profile and looking at the favorable hazard for both the groups, I think it's one of the valid options for the patients.
Thanks, Dr. Rakesh. I think you summarized so nicely how to choose patients and what risk, how the results are. So you exactly answered this question. So let me quickly go through. This is some aRCC data from the Indian scenario. And again, you can see here, the median PFS and overall survival are impressive. And we have some Indian data. I think none other than Dr. Akhil can throw some light on Indian data on aRCC. Dr. Akhil, your thoughts on microbiota you were just addressing in the chats, and also Indian data of aRCC. How do you look at that, Dr. Akhil? Dr. Akhil? I think we lost him. That's fine. So, and now coming on to the preferred TKI. Dr. Asim, I will come to you. So, if you look into the preferred TKI, so, we shouldn't call cabozantinib, lenvatinib, and sunitinib as targeted therapies. They're like chemotherapies. They're inhibiting every pathway, and the side effect is, you know how difficult it is to handle a sunitinib hand-foot syndrome or a cabozantinib diarrhea. So, if you look into axitinib, it is targeted. It is only inhibiting the VEGF pathway. So, looking into these data and also the half-life, the half-life is shortest for axitinib. Okay, so the thing is, let's say I had a patient of Nivo Cabo, and the patient developed diarrhea. So this is a real world case I'm just sharing with you. So Cabo diarrhea is said you stop cabozantinib, and let's see, a couple of days later, the patient came a couple of days later with an increasing incidence of diarrhea. And I realized the patient is looking sick. Then I admitted the patient, and then we looked for calprotectin and with a colonoscopy and a biopsy, and it is frank immune colitis. So if I had axitinib, I would expect the diarrhea to subside sooner. And cabozantinib half-life is so long, 5 weeks. So the diarrhea doesn't subside. So it is very difficult to differentiate between a TKI diarrhea versus IO diarrhea, and this may result in a delayed diagnosis of an IO colitis. So how do you look at the TKI choice? A sharp VEGF inhibitor with a shorter half-life, or a pan TKI with a long half-life? Yeah, Dr. Asim.
So, Dr. Chandrakant, you have thrown light on the real-world scenario. But generally, I start with the cabozantinib. Why? Because we learned over the period of time, the various pathways are involved in the RCC, and it blocks the multiple pathways, not only the VEGF. The other thing is how I do the practice is, it's not in India, it's not a 60 mg dose per patient. It's usually 40, and sometimes you need to go down to the 20 also. If you go on to chase the maximum dose, then there will be trouble. And we have seen the tremendous amount of response with the 20 mg of cabozantinib. But you ask the question of if patient has diarrhea with the Nivo and Cabo, how you will differentiate. So generally, the Nivo diarrhea, they come with the other symptoms also. Like patient must be having some skin reactions, or sometimes hepatitis, or sometimes the colitis. So there will be 2-3 mixing of the symptoms. If the diarrhea is also related with the cabozantinib, you stop the drug in the 3 days period of time. As the half-life is, though it is 5 days, but once the drug level comes down, it is going to be better. But the Nivo diarrhea, it takes time. So if you are little bit in the suspicion of the immune diarrhea, then you give the steroid, they respond immediately, almost many a times. If you have Cabo diarrhea, then you just stop the drug, give some anti-motility drugs, and then they will respond. Nivo diarrhea, they generally don't respond to the anti-motility drugs.
Thank you. So let us take expert opinion from Professor. So Professor Guillermo, so it's challenge for us. We miss out IO diarrhea, colitis, thinking it is a TKI, and you all know that starting methylprednisolone early is very important in any colitis or any IRAE. So how do you practically differentiate this? And again, your TKI of choice.
So one of the I guess the population is different from one side to another side. I know that in India, the tolerance of tyrosine kinase inhibitor is not as good as in Europe. That's my perception when I've been discussing with some of you about how is the tolerance with tyrosine kinase inhibitor. And obviously there could be many factors involved in this. So in that situation, that's why there are 2 important points here. First of all, is that sometimes you use generic drugs, right, instead of using the compound. So when you are using generic, there is always a small difference, but could be even more relevant depending on how has been designed that generic. So that's something to consider as well when your treatment is doing too much toxicity, like you may think about changing just in case is the kind of generic who is causing the issue. And the second one is like, because you have such a high incidence of diarrhea, I guess in your situation, axitinib is the best choice, because as I mentioned, the short life of axitinib helps you really to, when you have the axitinib, you know that the short life makes you think that if you stop treatment, you will recover from the toxicity very fast, which means like my patients, if they are on axitinib and they stop treatment, they recover in less than 1 day.
Thank you, Professor. Yeah. Right,
So
sir.
if your patients are having axitinib and they stop treatment and the following day they continue having diarrhea, you need to think about either is the compound that is giving you, in addition, in this case, the immunotherapy, or
Right.
there is other factors that are causing the diarrhea.
Thank you. Thank you again. Again, very important to manage an IO-TKI toxicity. The TKI should be safer. It should have a shorter half-life. That is the take-home, and that is what is evidenced in this. You can see that Pembro away head-to-head comparison. I mean, not head-to-head, like cross-trial comparison. You can see the pneumonitis rate and then the discontinuation rate, the steroid use rate, all are more with Pembro-Axi. So Ave-Axi looks much safer and smoother when compared to Pembro-Axi. And using steroids is concerning. And for maximum benefit, we do not want to have discontinuation. Steroid use and discontinuation, we know we do not want to do, and this hampers outcome. And this is again all combinations having almost similar efficacy, but the toxicity profile, especially you can focus on the steroid use, pneumonitis rate, and the discontinuation, all are better with Javelin Renal. And this is important. The quality of life discontinuation in steroid use, again, impressive with Ave-Axi. Ave-Axi is one of the safest one. And this is another table suggesting that you take pneumonitis or you take exacerbation of airway disease or pleural events or sarcoidosis, all are better with avelumab. Avelumab looks to be the safest IO among all, and axitinib is the safest TKI. So if you need a smooth induction of the initial course, Ave-Axi looks very promising. Again, these are some slides of acute kidney injury among the existing IO-TKIs. Again, Ave-Axi looks promising, and this is in different difficult subsets. Sarcomatoid component, dialysis, AKI, and elderly patients. This is in the sarcomatoid component. Ave-Axi looks promising. So let me go to Dr. Arun. Dr. Arun, sarcomatoid, we think that sarcomatoid dynasty using something like a IO, but look at this, sarcomatoid wherein hazard ratio is 0.57 with Ave-Axi. So difficult to treat disease, you have Ave-Axi. How impressed are you with this data?
So compared to IO, this IO-TK combination gives an excellent response. I'm excited to use, but in my practice, sarcomatoid variant, I always lose the patient.
20%? Yeah.
They will lose in 1 or 2 cycle. I lose the patient because the disease burden or the inadequate response. That is a nightmare. So personally,
Right.
I don't have.
Very important point. So sarcomatoid is an aggressive. You need quick responses, early separation. If I use IO, you will have 30% patients progressing in first 2 months, and therefore we need to be careful before giving IO. And this is the use of Ave-Axi in end-stage renal disease. Again, is one of the most renal safe, especially in hemodialysis patients also. And this is the comparator risk of AKI. This is a revision of the previous slide. Avelumab looks very safe. PD-L1 inhibitors are safer. And this is the efficacy in the elderly age population. So Dr. Anand, how often you see elderly RCCs in your population and how do you deal with them? Yes, Dr. Anand? If not, Dr. Burhan? No? Dr. Rakesh, your comments on all these difficult to treat subsets?
I think the elderly patients do have a lot of difficulty tolerating the TKIs when the combination of IO. The geriatric assessment is always a good thing to do, and we need to get to know the age is just a chronological number, and we need to assess the physiological stability. But despite all the precautions and everything, because of the polypharmacy, interactions of drugs, it becomes difficult to maintain them on the perfect dose. So I am much more comfortable with the axitinib dosing with variable dose selection that can happen with axitinib, and avelumab doesn't really trouble them, and all the adverse effects can be really controlled with just drugs and get to know whether it's because of the TKI, whether it's because of the immunotherapy. So I think overall the safety profile does suit the physiological capability of the elderly patients. But I would say that age is just a number, and we need to really look at the geriatric assessment and come to conclusion whether they can tolerate the drugs.
Thanks, Dr. Rakesh, for your inputs. Final message from Professor Guillermo, and then we can conclude. So, all your message for all of us for how to take aRCC into a clinical practice. So you're muted. Right.
Yeah, so yeah, I guess the most important thing about the whole message about what we've been discussing, I guess we need to remember that it's really important still the IMDC criteria. Hopefully we can move forward in the future with better biomarkers and better stratifications. But so far IMDC is showing that it's helping us to select better treatments. And for that favorable risk, IO combinations are suitable, especially with IO tyrosine kinase inhibitor, and in that situation, aXIAVELU has shown a really better hazard ratio compared with other IO tyrosine kinase inhibitor. When we think about IMDC poor risk groups, aVeluaxi 42% reductions in risk of death. That could be quite important for patients where you really need a response. So remember that IO plus tyrosine kinase inhibitor better response rate compared with other combinations, either IO. And when you talk about safety, critical due to long-term durations with aXIAVELU, we have lower discontinuations instead of use and better pulmonary safety. That's important when you're selecting your treatment, especially with, as I mentioned, for your populations where diarrhea is so important, axitinib may be a very good partner as combinations in the IO tyrosine kinase inhibitor, and definitely in the subgroups. In my opinion, remember that sarcomatoid will go always ipi/nivo first option, but if you're thinking second option, IO tyrosine kinase inhibitors such as aVeluaxi has also very good data, and also has data in very particular populations such as dialysis or kidney injury. So aXIAVELU, remember that's another good options because it strikes as a really good balance between safety and efficacy.
Thank you, Professor. I think pleasure hearing you. Very clear. So favorable risk, frail patient, poor risk. You want the safest IO-TKI combination. There you have aRCC in front of you. Strikes a balance of efficacy and safety. Thanks again, all the panelists, for your active participation. A special thanks to Professor for sharing his precious knowledge, very important learning points, brain mets, cabozantinib, and other information like favorable risk, how to choose an IO-TKI. Thank you. Thanks again so much. Over to you, Juhi.
Thank you so much, Chandrakant sir. Now I would like to conclude the session by saying thank you to all our experts for sharing their valuable perspectives, and definitely this dialogue adds greater depth to our understanding of RCC management, and I'm sure even our audience has taken a lot from this discussion. So thank you so much everyone, and wish you all a great evening and a great weekend ahead. Thank you.
Thank you. Good night, all of you.